and medications. Here's a detailed summary. Atrial Septal Defect, ASD. Diagnostic findings. Echocardiography, interatrial communication, right atrium and ventricle enlargement. ECG, incomplete right bundle branch block, right atrial enlargement. Chest X-ray, enlarged right atrium, right ventricle, and enhanced pulmonary vasculature. Treatment, medical management, rarely required unless associated with heart failure. Heart failure management, if present, diuretics, e.g. furosemide, beta blockers, e.g. carvedilol, ACE inhibitors, e.g. lisinopril, and digoxin. Surgical, interventional, transcatheter closure or surgical patch, especially for large shunts or right ventricular enlargement. Ventricular Septal Defect, VSD. Diagnostic findings. Echocardiography. Defect size, location, and shunt volume, pathological left to right blood flow. ECG. Signs of left ventricular hypertrophy in significant defects. Signs of right ventricular hypertrophy if pulmonary hypertension is present. Chest X-ray. Enhanced pulmonary vascular markings, left atrial and ventricular enlargement. Treatment, medical management for heart failure if present. Diuretics. Furosemide to reduce fluid overload. ACE inhibitors, enalapril to reduce afterload. Beta blockers. Carvedilol for heart rate control and to improve heart function. Digoxin improves cardiac contractility. Surgical, interventional, closure via surgical patch or transcatheter device for symptomatic and large defects or in the presence of significant left to right shunting leading to cardiac overload. General considerations for both ASD and VSD. Antibiotic prophylaxis for dental procedures in the presence of unrepaired or palliated defects to prevent infective endocarditis following the latest AHA guidelines. Monitoring, regular follow-up with echocardiography to assess defect size, heart function, and pulmonary pressures. Arrhythmia management, particularly for ASD, monitor for and manage supraventricular arrhythmias. Beta blockers, e.g. atenolol, or calcium channel blockers, e.g. diltiazem, may be used based on the arrhythmia type and patient tolerance. Educational points for specialists. Early detection and intervention are key to preventing long-term complications like pulmonary hypertension and heart failure. Individualized treatment planning is crucial, considering the defect size, symptomatic status, and presence of associated conditions. Understanding the genetic and environmental etiologies of CHDs aids in comprehensive patient care and counseling. This summary provides a foundation for specialist doctors to understand the critical aspects of diagnosing and managing ASD and VSD, incorporating specific treatments and medications relevant to their specialist practice. Clinical case, Atrial Septal Defect, ASD. Patient profile, age, 5 years, sex, female. Presenting complaint. The child is brought in by her parents due to less participation in physical activities compared to peers and becoming easily fatigued. History, medical history, no significant past medical history, normal developmental milestones. Family history, non-contributory. Physical examination, general, well-appearing child, no cyanosis. Vital signs, heart rate 95 BPM, blood pressure 160 mm/gram, respiratory rate 20 breaths min, oxygen saturation 98% on room air. Cardiovascular exam, regular rhythm, soft systolic ejection murmur, heard best at the upper left sternal border, and fixed splitting of the second heart sound, S2, noted. Respiratory exam, clear breath sounds bilaterally. Diagnostic workup, chest X-ray, mild cardiomegaly with increased pulmonary vascular markings. Electrocardiogram, ECG, right axis deviation, incomplete right bundle branch block. Echocardiography reveals a 10 mm secundum atrial septal defect with left to right shunting. Right atrial and ventricular dilation observed with no evidence of pulmonary hypertension. Management plan. Given the child's age, the size of the defect, and evidence of right heart volume overload, the decision is made to proceed with closure of the ASD. Interventional approach. Transcatheter device closure of the ASD is planned given the defect's amenable size and location. Pre-procedural care. Routine preoperative workup, including blood tests and a detailed echocardiogram to assess the rims around the defect for device anchoring. Post-procedural care. The child is monitored for any immediate post-procedure complications like arrhythmia or device migration. Discharge is planned for the next day if there are no complications. Follow-up. The child is scheduled for a follow-up visit in 1 month to assess the symptom improvement and echocardiogram to confirm the position of the device and the absence of residual shunting. Annual follow-ups are advised thereafter to monitor long-term outcomes and the development of any late complications. Discussion points. The timing of intervention in ASD depends on symptomatology, defect size, and evidence of right heart overload. Transcatheter device closure is preferred for secundum ASDs with adequate septal rims, while surgical repair is reserved for other types or in case of device contraindications. Long-term prognosis post-ASD closure is excellent, with most individuals leading a normal life, albeit with ongoing follow-up for potential late arrhythmias. Attached oral exam questions on atrial septal defect with answers. Question 1. Describe the pathophysiological effects of an atrial septal defect ASD on cardiac and pulmonary systems. Answer. An ASD allows oxygenated blood from the left atrium, LA, to flow into the right atrium, RA, due to the pressure differential between the atria, leading to a left-to-right shunt. This results in increased blood volume in the RA and right ventricle, RV, causing volume overload, RV dilation, and potentially RV hypertrophy over time. The increased blood flow to the lungs can cause pulmonary overcirculation, leading to pulmonary hypertension if left untreated. Question 2. What are the most common types of ASDs, and how are they differentiated on imaging? The most common types of ASDs include ostium secundum ASD, located in the center of the atrial septum. It's the most common type, best visualized on echocardiography in the apical four-chamber view. Ostium primum ASD, located lower in the atrial septum near the atrioventricular valves, often associated with AV valve abnormalities. Visualized on echocardiography with attention to AV valve involvement. Sinus venosus ASD, located near the entry of the superior or inferior vena cava. It may be associated with anomalous pulmonary venous return, identifiable on echocardiography and MRI. Question 3. Explain the significance of a fixed split S2 in ASD and the underlying mechanism. Answer. A fixed split S2 in ASD is due to the increased blood volume in the RA and RV, prolonging RV systole and delaying pulmonic valve closure. Unlike normal physiology, where the splitting of S2 varies with respiration, the splitting in ASD is fixed and does not vary significantly with inspiration or expiration due to the constant volume overload in the right side of the heart. Question 4. Discuss the criteria for closing an ASD and the available therapeutic options. Answer. ASD closure is indicated when there is evidence of right atrial or ventricular enlargement, significant left-to-right shunting leading to volume overload, or symptomatic patients with exercise intolerance or heart failure. Therapeutic options include transcatheter device closure, preferred for secundum ASDs with adequate septal rims. Surgical repair, indicated for larger defects, those involving inadequate rims for device closure, primum or sinus venosus ASDs, or when associated with other cardiac anomalies requiring correction. Question 5. What are potential complications of an untreated ASD and how might they influence patient management? Answer. Untreated ASD can lead to right heart volume overload, atrial arrhythmias such as atrial fibrillation, pulmonary hypertension, and Eisenmenger Syndrome in severe cases. These complications necessitate timely closure of the defect to prevent irreversible damage. In cases where pulmonary hypertension has developed, careful assessment and management by a specialized team are required to evaluate the feasibility and timing of closure. Question 6. How does the presence of an ASD influence the risk of stroke, and what is the mechanism behind this association? Answer. ASD can increase the risk of paradoxical embolism, where a thrombus formed in the venous system traverses the ASD to enter the systemic circulation, potentially leading to stroke. This risk underscores the importance of ASD closure in patients with cryptogenic stroke and evidence of a significant shunt, especially in the presence of a patent foramen ovale PFO or an ostium secundum ASD. These questions and answers cover critical aspects of ASD, focusing on pathophysiology, diagnostic criteria, management options, and complications, suitable for advanced medical professionals and specialists in cardiology. Ventricular Septal Defect, VSD, summary for specialist pediatric doctors and professors. Description: VSD is an abnormal opening between the left and right ventricles, leading to left to right blood shunting, resulting in volume overload on the right ventricle and pulmonary circulation. Epidemiology: it is the most prevalent congenital heart defect, with an incidence of approximately 4 per 1,000 live births. Etiology: associated with genetic syndromes like Down syndrome, Edwards syndrome, and Patau syndrome, and less commonly with Cri-du-Chat and Apert syndrome. Risk factors include intrauterine infections, TORCH, maternal diabetes, obesity, and smoking. Pathophysiology: typically located in the membranous part of the ventricular septum, leading to RV volume overload, pulmonary hypertension due to increased pulmonary flow, and LV volume overload due to recirculation. This condition results in biventricular hypertrophy and increased O2 saturation in the right ventricle and pulmonary artery. Clinical features: small defects, often asymptomatic, detected by a hollow systolic murmur. Medium to large defects, manifest with symptoms of heart failure, such as failure to thrive and recurrent respiratory infections, usually within the first 2 to 3 months of life. Auscultation, characterized by a harsh holosystolic murmur at the left lower sternal border, possibly accompanied by a mid-diastolic murmur and a loud pulmonic S2 in cases of pulmonary hypertension. A systolic thrill may be present. Diagnostic findings: echocardiography, definitive for detecting defect size, location, and shunt volume. Doppler can quantify shunt flow and pulmonary pressures. ECG shows biventricular hypertrophy in significant defects with signs of RV hypertrophy, including right axis deviation and P pulmonale. Chest X-ray demonstrates cardiomegaly, enhanced pulmonary vascular markings, and chamber enlargement based on defect size. Treatment: medical management for symptomatic infants includes diuretics, e.g. furosemide, to manage fluid overload, and ACE inhibitors, e.g. enalapril or captopril, for afterload reduction. Surgical repair recommended for infants with symptoms attributable to a large shunt or evidence of pulmonary hypertension. Methods include patch closure via open heart surgery. Follow-up echocardiography is crucial for monitoring post-repair. Endocarditis prophylaxis. Advised for patients pre- and post-repair undergoing certain procedures to prevent infective endocarditis. Complications. Untreated VSD can lead to arrhythmias, progressive heart failure, pulmonary hypertension with the risk of Eisenmenger Syndrome, infective endocarditis, and aortic regurgitation due to valve prolapse into the defect. This detailed overview integrates specific medical terminologies, diagnostic approaches, and treatment modalities for VSD, tailored for the educational needs of medical and dental professionals, students, and faculty. Clinical case: ventricular septal defect, VSD. Patient profile: age, 3 months, sex, male. Presenting complaint: the infant presents with poor feeding, rapid breathing, and failure to thrive. Clinical examination: vital signs, tachypnea, tachycardia. Physical exam: palpable thrill on the lower left sternal border. A prominent holosystolic murmur is auscultated at the same location. Diagnostic workup: chest X-ray shows cardiomegaly with increased pulmonary vascular markings indicating pulmonary overcirculation. Echocardiography reveals a large membranous VSD with significant left to right shunting. The left ventricle shows signs of volume overload. No evidence of pulmonary hypertension yet. ECG displays biventricular hypertrophy due to volume overload on both ventricles. Management plan. Given the patient's age, symptoms, and the size of the defect with significant shunting, surgical intervention is recommended. The plan includes preoperative, initiation of diuretics, e.g. furosemide, to reduce pulmonary congestion and improve symptoms. ACE inhibitors, e.g. captopril, are considered to reduce afterload, enhancing forward flow from the left ventricle. Surgical intervention, patch closure of the VSD during open heart surgery. Post-operative care, monitoring for arrhythmias, heart failure management, and prophylaxis for infective endocarditis during the recovery phase. Follow-up. The infant will require close follow-up to monitor cardiac function and growth. Repeat echocardiography will be essential to assess the success of the VSD closure and the function of both ventricles. Discussion points for specialists. The timing of surgery in infants with a large VSD and symptoms of heart failure is critical to prevent irreversible pulmonary vascular disease. Management of VSD-related pulmonary overcirculation with diuretics and afterload reduction preoperatively can stabilize the patient and optimize them for surgery. The technical aspects of patch closure, including the choice of material and technique, are crucial to ensure a successful outcome and minimize the risk of residual shunts or heart block. This clinical case emphasizes the pathophysiological consequences of a significant left-to-right shunt through a VSD, necessitating a detailed understanding of the hemodynamics involved, as well as the pharmacological and surgical management strategies tailored to pediatric patients with this congenital heart defect. Oral exam questions on ventricular septal defect, VSD, with answers. Question 1. Describe the pathophysiology of a ventricular septal defect and its impact on cardiac hemodynamics. Answer. A VSD creates an abnormal communication between the left and right ventricles. Due to the higher pressure in the left ventricle, blood is shunted left to right, leading to increased volume load on the right ventricle and pulmonary circulation. Over time, this can result in right ventricular hypertrophy and pulmonary hypertension. The excessive pulmonary blood flow can lead to pulmonary vascular disease and eventually Eisenmenger Syndrome if untreated. Question 2. How does the clinical presentation of a small VSD differ from that of a large VSD? Answer. Small VSDs often present asymptomatically due to minimal shunting that does not significantly overload the heart. They are typically detected by the presence of a characteristic holosystolic murmur during a routine examination. Large VSDs, however, can cause symptoms of heart failure in infancy, such as poor feeding, failure to thrive, recurrent respiratory infections, and tachypnea due to significant left-to-right shunting and pulmonary overcirculation. Question 3. What are the key echocardiographic findings in a patient with VSD? Answer. Echocardiography in VSD may reveal the defect's location and size, left-to-right shunt flow across the septum, right ventricular and pulmonary artery dilation, and left ventricular volume overload. Doppler imaging can quantify the shunt's severity and estimate pulmonary artery pressures. Question 4. Discuss the management options for VSD, including indications for surgical intervention. Answer. Management depends on VSD size, location, and clinical symptoms. Small, asymptomatic VSDs may require only observation and endocarditis prophylaxis. Moderate to large VSDs with significant shunting and symptoms of heart failure necessitate surgical closure to prevent complications like pulmonary hypertension. Indications for surgery include failure to thrive, uncontrolled heart failure, and evidence of increased pulmonary pressures. Question 5. What are potential complications of untreated VSD, and how might they alter the treatment approach? Answer. Complications of untreated VSD include Eisenmenger Syndrome, arrhythmias, aortic regurgitation in membranous VSDs due to aortic valve prolapse, and infective endocarditis. Development of Eisenmenger Syndrome, where pulmonary vascular resistance exceeds systemic resistance causing right-to-left shunt and cyanosis, contraindicates VSD closure due to the risk of severe systemic hypoxemia and heart failure. Question 6. How does one differentiate between the murmurs of VSD, Atrial Septal Defect, ASD, and patent Ductus Arteriosus, PDA, on auscultation? Answer. VSD murmur is a hollow systolic murmur best heard at the lower left sternal border, often with a palpable thrill. ASD typically presents with a systolic ejection murmur due to increased flow across the pulmonic valve and a fixed split S2. PDA murmur is continuous, often described as a machinery murmur, best heard at the left upper sternal border. Atrioventricular Septal Defect, AVSD. Summary. Definition: AVSD encompasses defects involving the atrioventricular valves, mitral and tricuspid, and the atrial and/or ventricular septum. It's characterized by complete form, combination of ASD and VSD with a common AV valve. Partial form, primarily involves ASD and minor abnormalities of the AV valves. Etiology: strong association with Down syndrome, correlations with maternal diabetes and obesity. Pathophysiology: complete AVSD. Results in atrial and ventricular left to right shunts leading to excessive pulmonary blood flow, biventricular volume overload, pulmonary hypertension, and heart failure. Partial AVSD involves an atrial left to right shunt with potential for minimal symptoms into adulthood. Both forms can exhibit AV regurgitation contributing to in utero heart failure. Clinical features: complete form, symptoms align with significant heart failure and pulmonary hypertension. Partial form may present subtly with exertional dyspnea or be asymptomatic for extended periods. Diagnostics: antenatal echocardiography can reveal endocardial cushion defects early, prompting Down syndrome screening. Echocardiography, essential for defining defect size, shunt volumes, and assessing AV valve function. ECG may show left axis deviation indicative of left ventricular hypertrophy, LVH. Chest X-ray demonstrates global cardiomegaly in the complete form and right heart enlargement in the partial form. Treatment: medical management includes standard therapy for heart failure, diuretics like furosemide, ACE inhibitors such as enalapril or lisinopril, and inotropic agents like digoxin, and pulmonary hypertension, e.g. sildenafil, a phosphodiesterase type 5 inhibitor, or bosentan, an endothelin receptor antagonist. Surgical management necessitates patch closure of septal defects and reconstruction of AV valves. This approach is tailored based on the defect's complexity and the patient's hemodynamic status. Specific drug classes for AVSD management: diuretics, used to manage volume overload; ACE inhibitors, ARBs, employed to reduce afterload, improving forward flow and reducing regurgitant volume; beta blockers can be used for heart rate control and to improve myocardial function; inotropes, e.g. digoxin, utilized to enhance myocardial contractility in patients with reduced systolic function; pulmonary vasodilators, e.g. sildenafil, bosentan, for managing pulmonary hypertension secondary to increased pulmonary blood flow. Educational points for specialists: understanding the complex anatomy of AVSD is crucial for accurate diagnosis and management. Surgical intervention requires meticulous planning to address both septal defects and valve abnormalities, with long-term follow-up to monitor for residual defects, valve function, and potential arrhythmias. Genetic counseling is recommended for families, given the association with chromosomal abnormalities such as Down syndrome. Clinical case: Atrioventricular Septal Defect, AVSD. Patient profile: age, 6 months, sex, male, background, diagnosed with Down syndrome postnatally. Presenting complaint: the infant presents with poor feeding, rapid breathing, and failure to thrive. The parents also report frequent respiratory infections. History: prenatal, no significant issues reported during pregnancy. Down syndrome diagnosis confirmed postnatally. Family history: no known congenital heart diseases or genetic disorders in the family. Physical examination: general. The infant appears small for his age with features suggestive of Down syndrome. Vital signs: tachypnea, mild tachycardia, and oxygen saturation of 95% on room air. Cardiovascular exam: a grade 3/6 pansystolic murmur, best heard at the left lower sternal border with a diastolic component. A thrill is palpable over the same area. Diagnostic workup: chest X-ray shows cardiomegaly with increased pulmonary vascular markings, suggestive of pulmonary overcirculation. Echocardiography reveals a large complete AVSD with a significant left-to-right shunt, common AV valve regurgitation, and mild pulmonary hypertension. ECG indicates biventricular hypertrophy and left axis deviation. Management plan: given the significant symptoms, size of the defect, and evidence of pulmonary overcirculation and hypertension, surgical intervention is planned. Preoperative care: initiation of diuretics, e.g. furosemide, to manage pulmonary congestion, and ACE inhibitors, e.g. captopril, to reduce afterload. Surgical intervention: complete repair involving patch closure of the septal defects and separation reconstruction of the common AV valve into mitral and tricuspid components. Postoperative care: monitoring for arrhythmias, heart failure management, and careful observation for AV valve function. Follow-up: the infant will require close monitoring in a pediatric cardiology clinic with regular follow-up appointments to assess growth, development, and cardiac function post-repair. The focus will be on monitoring for residual shunts, valve function, and the potential development of pulmonary hypertension. Discussion points for specialists: the complexity of AVSD repair, particularly in the setting of Down syndrome, where there may be additional challenges related to the patient's overall health and associated comorbidities. The importance of a multidisciplinary approach, including genetics, cardiology, cardiothoracic surgery, and pediatric care, to optimize outcomes for patients with AVSD. Long-term management considerations, including the risk of residual defects, the need for reintervention, and the potential development of arrhythmias. Oral exam questions on Atrioventricular Septal Defect, AVSD, with answers. Question 1. Define Atrioventricular Septal Defect, AVSD, and describe its two main forms. Answer: AVSD is a congenital heart defect involving abnormalities in the atrial and ventricular septa and the atrioventricular AV valves. The two main forms are complete heat AVSD, characterized by a large central defect involving both the atrial and ventricular septa with a common AV valve. Partial AVSD involves defects primarily in the atrial septum, ASD, and sometimes the ventricular septum, VSD, with separate left and right AV valves, though one or both may be malformed. Question 2. Discuss the association between AVSD and genetic syndromes. Answer: AVSD is strongly associated with Down syndrome, trisomy 21, with a significant percentage of Down syndrome patients having some form of AVSD. Other chromosomal anomalies may also be associated, but the link with Down syndrome is the most prominent. Question 3. Explain the pathophysiological consequences of a complete AVSD on cardiac function and pulmonary circulation. Answer: in complete AVSD, the combined atrial and ventricular septal defects lead to significant left-to-right shunting of blood. This results in volume overload of the right heart chambers and increased blood flow to the lungs, causing pulmonary overcirculation. Over time, this can lead to pulmonary hypertension, right heart failure, and eventually bidirectional or right-to-left shunting, Eisenmenger Syndrome, if uncorrected. Question 4. How is AVSD diagnosed prenatally and postnatally? Prenatally, AVSD can be diagnosed through fetal echocardiography, often during the second trimester ultrasound screening, showing the common AV valve and septal defects. Postnatally, diagnosis is confirmed through echocardiography, demonstrating the septal defects, common AV valve, and the extent of valve regurgitation. Additional findings may include ECG changes indicative of biventricular hypertrophy and chest X-ray findings of cardiomegaly and increased pulmonary vascular markings. Question 5. Describe the surgical management of AVSD and the timing considerations for intervention. Answer: surgical repair is the definitive treatment for AVSD and typically involves complete AVSD, patch closure of the atrial and ventricular septal defects, separation of the common AV valve into mitral and tricuspid components, and valve reconstruction to address regurgitation. Partial AVSD, patch closure of the ASD and, if present, the VSD, with repair or reconstruction of the AV valves as needed. Timing of surgery depends on the severity of symptoms, degree of heart failure, and presence of pulmonary hypertension, but it is generally performed within the first few months to years of life to prevent irreversible pulmonary vascular disease. Question 6. What are the long-term outcomes and potential complications following surgical repair of AVSD? Answer: long-term outcomes post-AVSD repair are generally favorable with proper surgical intervention. However, patients may have complications such as residual shunts, AV valve regurgitation, arrhythmias, or pulmonary hypertension. Lifelong cardiac follow-up is essential to monitor and manage these potential issues.
Atrioventricular Septal Defect, AVSD. Summary: AVSD involves defects in the atrioventricular valves, mitral and tricuspid, and the septa, dividing the atria and ventricles. It includes a complete form with both ASD-MSD and a common AV valve, and a partial form featuring only ASD and minor AV valve abnormalities. Etiology: strongly associated with chromosomal anomalies, particularly Down syndrome. Maternal diabetes and obesity are notable risk factors. Pathophysiology: complete AVSD causes atrial and ventricular shunting, leading to excessive pulmonary blood flow, biventricular overload, pulmonary hypertension, and heart failure. Partial AVSD involves an atrial shunt, potentially resulting in less pronounced symptoms, but can still lead to AV valve regurgitation and potential heart failure. Clinical features: complete AVSD presents early in life with signs of significant heart failure and pulmonary overcirculation. Partial AVSD may have milder symptoms or be asymptomatic initially, but can manifest with exercise intolerance or heart failure signs in later life. Diagnostics: antenatal echocardiography can identify endocardial cushion defects for early Down syndrome screening. Echocardiography, essential for defining the defect's anatomy, shunt volumes, and evaluating AV valve function. Reveals septal defects, common AV valve incomplete AVSD, and valve regurgitation. E shows left axis deviation and signs of biventricular hypertrophy. Chest X-ray indicates cardiomegaly and increased pulmonary blood flow. Treatment: medical management. For heart failure, diuretics, e.g. furosemide, ACE inhibitors, e.g. enalapril for afterload reduction, and inotropic agents, e.g. digoxin for improved myocardial contractility. For pulmonary hypertension, sildenafil, a phosphodiesterase 5 inhibitor, or bosentan, an endothelin receptor antagonist, to reduce pulmonary vascular resistance. Surgical management: patch closure of septal defects and reconstruction of the AV valves. Timing of surgery is critical, often within the first year of life, for complete AVSD to prevent irreversible pulmonary vascular disease. Specialist considerations: a comprehensive understanding of AVSD anatomy via echocardiography is vital for surgical planning. Long-term follow-up is required to monitor for residual defects, valve function, arrhythmias, and pulmonary hypertension. Genetic counseling is recommended due to the association with Down syndrome and other chromosomal anomalies. This summary encapsulates crucial information for specialists, focusing on specific medical and surgical interventions, supported by detailed diagnostic findings for AVSD. Clinical case: Atrioventricular Septal Defect, AVSD. Patient profile: age 4 months, sex female, background diagnosed with Down syndrome during neonatal screening. Presenting complaint: the infant's parents report significant tiring during feeds, poor weight gain, and increased work of breathing. History: birth history, full term via spontaneous vaginal delivery with no immediate postnatal issues. Down syndrome diagnosis confirmed postnatally. Family history, non-contributory for congenital heart disease. Physical examination: general mild cyanosis noted at rest, exacerbated during feeding. Vital signs: mild tachypnea, heart rate elevated, oxygen saturation 92% on room air. Cardiovascular exam: a loud, harsh murmur best heard at the lower left sternal border, no palpable thrill. Respiratory exam: mild subcostal retractions, clear lung fields. Diagnostic workup: chest x-ray, cardiomegaly with increased pulmonary vascular markings suggestive of pulmonary overcirculation. Echocardiography demonstrates a large complete AVSD with significant left-to-right shunting at both atrial and ventricular levels, a common AV valve with moderate regurgitation, and signs of beginning pulmonary hypertension. ECG: biventricular hypertrophy with left axis deviation. Management plan: given the symptomatic nature of the AVSD, significant shunting, and early signs of pulmonary hypertension, early surgical intervention is indicated. Preoperative: initiation of diuretic therapy, e.g. furosemide, to manage symptoms of congestive heart failure and improve pulmonary overcirculation. Surgical intervention: complete AVSD repair, including patch closure of the atrial and ventricular septal defects and separation of the common AV valve into mitral and tricuspid components, along with valve repair to address the regurgitation. Postoperative care: monitoring in the intensive care unit for arrhythmias, heart failure management, and ensuring the adequacy of the surgical repair. Follow-up: the infant requires close follow-up in a specialized pediatric cardiology clinic with repeat echocardiograms to monitor the repair's success, valve function, and pulmonary pressures. Long-term follow-up will focus on growth, development, and potential late complications, such as arrhythmias or residual shunts. Discussion points for specialists: the importance of early diagnosis and timely surgical intervention in AVSD to prevent irreversible damage due to pulmonary hypertension and ensure optimal developmental outcomes. The challenges of AVSD repair in the context of Down syndrome, given potential comorbidities and the need for a multidisciplinary approach to care. The role of genetic counseling and support services for families of children with AVSD and associated chromosomal abnormalities. Oral exam questions on Atrioventricular Septal Defect, AVSD, with answers. Question 1. What distinguishes a complete AVSD from a partial AVSD in terms of anatomical defects and clinical presentation? Answer. A complete AVSD involves defects in both the atrial and ventricular septa, along with a common atrioventricular valve that crosses the septal defects, resulting in significant left-to-right shunt at both atrial and ventricular levels. Clinically, it presents early in life with signs of heart failure and pulmonary overcirculation. A partial AVSD, on the other hand, typically involves a defect in the atrial septum and sometimes in the ventricular septum, with less pronounced shunting and may present later in life or remain asymptomatic for longer periods. Question 2. How does the presence of Down syndrome influence the management and prognosis of patients with AVSD? Answer. Patients with Down syndrome and AVSD may have other associated health issues that could complicate their management, such as pulmonary hypertension, respiratory complications, and potential challenges related to surgical interventions. Their overall prognosis might be influenced by these factors, necessitating a multidisciplinary approach to care. However, with appropriate surgical correction of the AVSD, many individuals with Down syndrome can have significantly improved cardiac outcomes and quality of life. Question 3. Describe the typical echocardiographic findings in a patient with complete AVSD. Answer. Echocardiography in complete AVSD typically shows a large central defect involving both the atrial and ventricular septa, a common AV valve straddling the defect, and varying degrees of AV valve regurgitation. There may also be evidence of right and left ventricular dilation and signs of increased pulmonary blood flow. Pulmonary artery pressures can be estimated to assess for pulmonary hypertension. Question 4. What are the surgical principles in the repair of complete AVSD, and what are the potential post-operative complications? Answer. Surgical repair of complete AVSD involves closure of the atrial and ventricular septal defects using patch material and separation and reconstruction of the common AV valve into distinct mitral and tricuspid valves. Potential postoperative complications include residual septal defects, AV valve regurgitation, heart block requiring pacemaker implantation, and pulmonary hypertension. Question 5. Discuss the role of antenatal echocardiography in the diagnosis of AVSD and its implications for perinatal care. Answer. Antenatal echocardiography can identify AVSD as early as the first trimester, allowing for early diagnosis and planning of perinatal care. It enables multidisciplinary team involvement early on, including cardiology, genetics, and neonatology, to manage the neonate's condition immediately after birth, optimize timing for surgical intervention, and provide genetic counseling for the parents. Question 6. Explain the pathophysiological mechanism leading to heart failure in infants with untreated AVSD. Answer. Untreated AVSD results in significant left-to-right shunting at both the atrial and ventricular levels, leading to volume overload in the right heart chambers and increased pulmonary blood flow. This chronic volume overload causes biventricular dilation and hypertrophy, and the excessive pulmonary circulation can lead to pulmonary hypertension. Together, these changes strain the heart's ability to function effectively, leading to heart failure symptoms. Patent foramen ovale. Description. PFO is a common cardiac anatomical variant where the foramen ovale, a normal fetal cardiac structure, fails to fully close after birth, maintaining a potential communication between the left and right atria. Epidemiology. Approximately 25% of the general population has a PFO, making it a relatively common condition. Etiology. While the exact cause of PFO persistence is not fully understood, it's associated with conditions like Loeys-Dietz syndrome and possibly genetic factors. Pathophysiology. Normally, the foramen ovale closes shortly after birth as the pressure in the left atrium exceeds that in the right, sealing the septum primum against the septum secundum. In PFO, this fusion is incomplete, allowing for potential shunting, especially during conditions that increase right atrial pressure, e.g. Valsalva maneuver. Clinical features. Most individuals with PFO are asymptomatic. Symptoms, when present, are usually related to complications like paradoxical embolism leading to stroke. Diagnostics. Transthoracic echocardiography, TTE with agitated saline, best initial test to detect right to left shunting through the PFO. Transesophageal echocardiography, used when TTE results are inconclusive or when there's a high index of suspicion for PFO despite negative TTE findings. Treatment. Asymptomatic PFO. Generally, no treatment is required. Symptomatic PFO, post-embolic events. Management includes antithrombotic therapy, antiplatelet agents or anticoagulants depending on the clinical scenario. Closure. Considered for patients with recurrent embolic events despite medical therapy, using percutaneous devices for defect closure. Complications. Paradoxical embolism. A venous thrombus passes through the PFO to the arterial system, potentially causing ischemic stroke or other systemic embolisms. Ischemic stroke, particularly in the context of cryptogenic stroke where PFO might serve as a conduit for emboli. Educational points for specialists. Recognizing PFO as a potential source of cryptogenic stroke, particularly in younger patients without traditional risk factors for cerebrovascular disease. The decision for PFO closure requires careful consideration of the patient's overall risk profile, including the risk of recurrent embolic events and the potential complications of closure devices. The role of multidisciplinary teams, including cardiology and neurology, in the evaluation and management of patients with PFO and related complications. Clinical case, patent foramen ovale PFO. Patient profile, age 32 years, sex, female, occupation, software engineer. Presenting complaint. The patient presents to the emergency department with acute onset of right-sided weakness and difficulty speaking that started 2 hours ago. History, medical history, unremarkable. No known history of heart disease, hypertension, diabetes, or hyperlipidemia. Family history, non-contributory. Social history, non-smoker, occasional alcohol, no recreational drug use. Recently returned from a long-haul flight. Physical examination, neurological exam, noted right-sided hemiparesis and expressive aphasia. NIH stroke scale score is 8. Cardiovascular exam, regular heart rate and rhythm, no murmurs, rubs, or gallops, no peripheral edema. Diagnostic workup, brain MRI, reveals an acute infarct in the left middle cerebral artery territory. Carotid ultrasound, no significant stenosis. Echocardiography, no structural heart disease, but bubble study shows evidence of right-to-left shunt suggestive of PFO. TE with agitated saline contrast confirms the presence of a PFO with right-to-left shunting during Valsalva maneuver. Management plan. Given the presentation of cryptogenic stroke potentially related to the identified PFO, a multidisciplinary team involving neurology and cardiology is consulted to discuss management options. Acute stroke management. Initiation of antiplatelet therapy with aspirin. PFO management. Conservative. Continuation of antiplatelet therapy and risk factor modification. Interventional. Given the patient's age, lack of traditional stroke risk factors, and the presence of PFO, the team considers percutaneous PFO closure. The decision is made in collaboration with the patient after discussing the potential benefits and risks. Follow-up. The patient is scheduled for close follow-up appointments with both neurology and cardiology. Plans include monitoring for any recurrent neurological symptoms and reassessment of the PFO closure need based on symptomatology and lifestyle factors. Discussion points for specialists. The need for a thorough workup in young patients with cryptogenic stroke to identify potential causes like PFO. The importance of a multidisciplinary approach in managing patients with PFO and cryptogenic stroke, balancing the benefits of closure against procedural risks. The role of lifestyle and risk factor modification in secondary stroke prevention. Oral exam questions on patent foramen ovale PFO with answers. Question 1. What is a patent foramen ovale PFO, and how does it differ from an atrial septal defect, ASD? A PFO is a remnant flap-like opening between the atrial septa that fails to fuse after birth, allowing potential blood flow between the right and left atria under certain conditions. Unlike ASD, which is a true septal defect, a PFO is a persistent fetal structure where the septum primum and septum secundum haven't fully sealed. ASD involves a deficiency in the septal tissue, creating a constant left-to-right shunt, whereas PFO can allow for bidirectional flow depending on the atrial pressure gradients. Question 2. How is a PFO clinically significant, particularly in relation to cerebrovascular events? Answer. A PFO can be clinically significant in the setting of paradoxical embolism. This occurs when a venous thrombus passes through the PFO to the arterial circulation, potentially leading to ischemic stroke or other systemic embolic events. PFO is often investigated in the context of cryptogenic strokes, especially in younger patients without traditional cardiovascular risk factors. Question 3. Describe the diagnostic modalities used to identify a PFO and the rationale behind each. Answer. Transthoracic echocardiography with bubble study, non-invasive and widely available, useful for initial screening. The injection of agitated saline creates bubbles that can be seen crossing from the right to the left atrium through the PFO during maneuvers like Valsalva that increase right atrial pressure. Transesophageal echocardiography, TE, with bubble study, provides a more detailed view of the atrial septum and can more reliably detect a PFO, especially in cases where TTE is inconclusive. Question 4. Discuss the management strategies for PFO, particularly in the context of cryptogenic stroke. Answer. Management strategies for PFO after a cryptogenic stroke involve weighing the risk of recurrent stroke against the risks associated with treatment options. Medical management typically involves antiplatelet therapy, e.g. aspirin or anticoagulation, depending on individual risk factors. Percutaneous closure, considered for patients with recurrent cryptogenic stroke despite medical therapy, or in those with high-risk features on echocardiography, e.g. large shunt, atrial septal aneurysm. This involves the transcatheter placement of a closure device to seal the PFO. Question 5. What are the potential complications of PFO closure, and how are they mitigated? Answer. Complications of PFO closure can include device-related thrombus formation, residual shunting, atrial arrhythmias, and rarely, device erosion or migration. Mitigation strategies involve careful patient selection, meticulous procedural technique, use of imaging guidance, and post-procedure anticoagulation or antiplatelet therapy to reduce thrombotic risk. Question 6. In what scenarios might PFO closure be considered over medical management alone? Answer. PFO closure might be favored over medical management in patients with recurrent cryptogenic strokes, despite optimal medical therapy, particularly if they are young and have no other apparent stroke etiologies. It may also be considered in individuals with a high-risk PFO anatomy, e.g. large shunt-associated atrial septal aneurysm, or in certain occupational contexts where even a single recurrent stroke could have catastrophic consequences, e.g. commercial pilots. Patent Ductus Arteriosus, PDA summary, description. PDA is characterized by the failure of the ductus arteriosus, a fetal vascular connection between the aorta and pulmonary artery, to close after birth, leading to an abnormal blood flow pattern. Epidemiology, more common in premature infants, 20 to 60%, than in full-term births, 5 to 10%. Female predominance with a 2.1 ratio compared to males. Etiology, factors contributing to PDA include prematurity, maternal rubella infection, alcohol consumption during pregnancy, use of certain medications like phenytoin, and conditions such as respiratory distress syndrome and certain trisomies, notably Down syndrome. Pathophysiology. Normally closing shortly after birth, the patent ductus arteriosus results in a left-to-right shunt due to the reversal of pressure gradients between the aorta and pulmonary artery, leading to volume overload in the pulmonary circulation and left heart, potentially causing heart failure. Clinical features. Small PDA, often asymptomatic, detected incidentally. Large PDA presents with failure to thrive, signs of heart failure in infancy, bounding peripheral pulses, wide pulse pressure, and a distinct continuous machinery murmur. Diagnostics. Echocardiography, the gold standard, showing left atrial and ventricular dilatation, shunt volume, and pulmonary artery pressure. ECG may indicate left ventricular hypertrophy, LVH, in significant PDA. Chest X-ray demonstrates increased pulmonary vasculature and cardiomegaly. Cardiac catheterization, reserved for complex cases or prior to intervention. Treatment. Medical management. Indomethacin or ibuprofen to encourage closure in premature infants by inhibiting prostaglandin synthesis, crucial for keeping the ductus arteriosus open. Surgical ligation. Traditional approach for PDA closure when pharmacological treatment is ineffective or contraindicated. Transcatheter occlusion, preferred in older children and adults, involving the placement of a device to occlude the PDA percutaneously. Special considerations. Premature infants. Management is more complex due to the risks associated with both the PDA and treatment interventions, requiring a multidisciplinary approach. Ductal-dependent CHDs. In these cases, the PDA is essential for survival, necessitating prostaglandin E1 infusion to maintain ductal patency until definitive surgical treatment can be performed. Complications. Untreated PDA can lead to complications such as infective endocarditis, heart failure, and potentially Eisenmenger Syndrome due to prolonged exposure to increased pulmonary blood flow and pressure, leading to pulmonary vascular disease. Educational points for specialists. Understanding the nuances of PDA presentation, particularly in the context of prematurity and associated comorbidities, is essential. The choice of treatment should be tailored to the individual patient, considering the size of the PDA, the presence of symptoms, and the risk of complications. Clinical case: patent ductus arteriosus. Patient profile: age 6 weeks, sex female, birth history born at 35 weeks gestation with a birth weight of 2.2 kilograms. Presenting complaint: the infant's parents report poor feeding, increased work of breathing, and failure to gain weight adequately since birth. History: medical history. Noted respiratory distress shortly after birth, requiring supplemental oxygen for the first few days of life. No significant illnesses since. Family history: non-contributory. Physical examination: general. The infant appears small for her age and mildly tachypneic. Vital signs: mild tachycardia, normal blood pressure, respiratory rate elevated, oxygen saturation 95% on room air. Cardiovascular exam: a continuous machinery-like murmur best heard at the left infraclavicular area. Bounding peripheral pulses and wide pulse pressure are noted. Respiratory exam: mild intercostal retractions, but lungs are clear to auscultation. Diagnostic workup: chest X-ray shows cardiomegaly and increased pulmonary vascular markings, suggestive of increased pulmonary blood flow. Echocardiography confirms a moderate-sized PDA with significant left-to-right shunt, leading to left atrial and ventricular volume overload. No evidence of pulmonary hypertension. Management plan: given the symptomatic nature of the PDA and evidence of hemodynamic significance, initial medical management, initiation of diuretic therapy, e.g., furosemide, to reduce pulmonary congestion and improve symptoms. Consideration for closure: due to the persistent symptoms and evidence of volume overload, the decision is made to proceed with closure of the PDA. Transcatheter occlusion: chosen as the preferred method due to its less invasive nature and good success rate, planned for the coming weeks. Follow-up: the infant is scheduled for close monitoring of weight and development, with follow-up echocardiography post-procedure to assess the success of the PDA closure and the resolution of left heart volume overload. Discussion points for specialists: the importance of early identification and intervention in symptomatic PDA to prevent long-term complications such as heart failure and pulmonary hypertension. The role of diuretics in managing symptoms of heart failure in infants with significant left-to-right shunts. The decision-making process in choosing between transcatheter and surgical closure methods, considering the size of the PDA, the age and clinical condition of the patient, and the institutional capabilities. Oral exam questions on patent ductus arteriosus, PDA with answers. Question 1. Define patent ductus arteriosus PDA and explain its pathophysiological impact on the cardiovascular system. Answer. Patent ductus arteriosus, PDA, is a congenital condition where the ductus arteriosus fails to close after birth, maintaining an abnormal connection between the aorta and the pulmonary artery. This results in a left-to-right shunt, leading to increased pulmonary blood flow, volume overload in the left atrium and ventricle, and potentially leading to heart failure and pulmonary hypertension if untreated. Question 2. What are the common clinical signs and symptoms of a significant PDA in infants? Answer. Significant PDA in infants can present with symptoms of heart failure such as poor feeding, failure to thrive, respiratory distress, and frequent respiratory infections. Clinically, it's characterized by bounding peripheral pulses, wide pulse pressure, a continuous machinery murmur best heard in the left infraclavicular region, and signs of volume overload on echocardiography. Question 3. How is PDA diagnosed, and what are the key findings on diagnostic tests? Answer. PDA is primarily diagnosed with echocardiography, which shows the patent ductus, quantifies the shunt size, and assesses the impact on cardiac chambers. A chest X-ray may show cardiomegaly and increased pulmonary vascular markings. The ECG might display signs of left ventricular hypertrophy in significant PDAs. The characteristic continuous machinery murmur can be heard on auscultation. Question 4. Discuss the management options for PDA, including indications for each. Answer. Management of PDA includes medical management. Indomethacin or ibuprofen can be used to pharmacologically close the PDA in premature infants by inhibiting prostaglandin synthesis. Transcatheter occlusion, preferred in older children and adults, especially for small to moderate-sized PDAs, as it's less invasive. Surgical ligation, recommended for large PDAs, those that fail medical or transcatheter closure, or in cases where the PDA is complicated by infective endocarditis. Question 5. What are the potential complications of untreated PDA, and how do they influence treatment decisions? Answer. Untreated PDA can lead to complications such as infective endocarditis, pulmonary hypertension, Eisenmenger syndrome, and congestive heart failure. The risk of these complications often dictates the urgency and method of closure, with symptomatic infants and those with large shunts requiring more prompt intervention. Question 6. In the context of a premature infant with a PDA, what factors influence the decision between medical management and interventional closure? Answer. In premature infants, the decision between medical management and interventional closure is influenced by the PDA's size, the infant's response to medical therapy, the presence of symptoms, e.g. respiratory distress, failure to thrive, and the risk of complications, e.g. necrotizing enterocolitis with medical management. Interventional closure is considered when medical management is ineffective or contraindicated, and the PDA is contributing to significant clinical symptoms. Coarctation of the aorta, Comrie. Definition: coarctation of the aorta, CoA, is characterized by a congenital narrowing of the aorta, typically located at the aortic isthmus just distal to the left subclavian artery origin, leading to obstructed blood flow from the heart to the lower part of the body. Epidemiology: prevalence is about 3 per 10,000 live births, with a higher incidence in males than females. Etiology: congenital factors. The exact cause is often unknown, but associations include genetic syndromes like Turner syndrome and cardiac anomalies such as bicuspid aortic valve, VSD, and PDA. Acquired causes. Rare, but can include conditions like Takayasu arteritis or severe atherosclerosis. Pathophysiology. CoA leads to increased pressure proximal to the obstruction, upper body, and decreased pressure distal to it, lower body, causing hypertension in the upper extremities, and weakened pulses in the lower extremities. Over time, collateral circulation develops, and left ventricular hypertrophy may occur due to increased workload. Clinical features. Neonates may present with heart failure if severe, especially once the PDA closes. Older children and adults might show hypertension, differential blood pressure between upper and lower limbs, diminished or delayed femoral pulses, brachial femoral delay, and signs of collateral circulation, e.g. rib notching on X-ray. Diagnostics. Blood pressure measurements. Discrepancy in blood pressure between upper and lower extremities. Echocardiography, main diagnostic tool showing the site and severity of coarctation and associated cardiac anomalies. Chest X-ray, may show cardiomegaly, rib notching, and the figure of 3 sign. MRI-CT angiography, used for detailed anatomical assessment, especially in older children and adults. ECG might show right ventricular hypertrophy in neonates and left ventricular hypertrophy in older children and adults. Treatment: Prostaglandin E1 infusion in neonates with critical coarctation to maintain ductal patency and ensure lower body perfusion until definitive treatment. Surgical correction. The traditional approach, especially in neonates and infants, involves resection of the narrowed segment with end-to-end anastomosis, patch aortoplasty, or other surgical techniques. Balloon angioplasty and stent placement. Considered in older children and adults, particularly for recoarctation after initial surgery. Complications. Long-standing coarctation can lead to complications such as persistent hypertension, aortic aneurysm or dissection, cerebral aneurysms, and premature coronary artery disease. Educational points for specialists. Early detection and intervention are crucial to prevent complications associated with chronic hypertension and altered hemodynamics. Long-term follow-up is essential for detecting recoarctation, aortic aneurysms, and managing hypertension. A multidisciplinary approach involving pediatric cardiologists, cardiothoracic surgeons, and other specialists is key to managing complex cases and associated anomalies. Clinical case, coarctation of the aorta, CoA. Patient profile, age 3 months, sex male. Presenting complaint, the infant's parents report poor feeding, increased irritability, and less vigorous activity. The pediatrician noted a significant discrepancy in pulse strength between the upper and lower extremities during a routine checkup. History, birth history, full term via normal vaginal delivery, no complications noted at birth. Birth weight was within normal limits. Family history. No known family history of congenital heart diseases. Physical examination. General. The infant appears slightly pale and less active than expected for age. Vital signs. Blood pressure is noted to be higher in the upper extremities compared to the lower extremities. Mild tachycardia is present. Cardiovascular exam. Normal S1 and S2, with a systolic murmur heard best at the back and left infraclavicular area. Femoral pulses are weak compared to brachial pulses. Other exams. No significant findings. Diagnostic workup. Chest X-ray shows mild cardiomegaly and possible rib notching. Echocardiography reveals narrowing of the aorta just distal to the left subclavian artery origin, with a significant gradient across the coarctation site. Left ventricular function is normal, and no other structural anomalies are noted. Blood pressure measurements documented higher blood pressure readings in the arms than in the legs. MRI of aorta confirms the coarctation site and extent and evaluates for collateral circulation. Management plan. Given the significant gradient and the presence of symptoms, surgical intervention is recommended. Preoperative. Initiate measures to manage heart failure symptoms if present, including diuretics such as furosemide. Surgical correction. End-to-end anastomosis following resection of the coarcted segment is planned, considering the infant's age and anatomy. Postoperative care. Close monitoring of blood pressure, heart function, and wound healing. Prophylactic antibiotics may be administered to prevent infective endocarditis during the immediate postoperative period. Follow-up. The infant will require regular follow-up with pediatric cardiology to monitor for potential recoarctation, hypertension management, and overall cardiac function. Serial echocardiograms will be part of routine surveillance. Discussion points for specialists. The importance of early detection and intervention in CoA to prevent long-term complications such as hypertension, heart failure, and cerebrovascular accidents. The role of a multidisciplinary team in managing CoA, from diagnosis through long-term follow-up, including pediatric cardiologists, cardiothoracic surgeons, and pediatricians. The need for lifelong surveillance in individuals with CoA, even after successful repair, due to the risk of recoarctation and other cardiovascular complications. Oral exam questions on coarctation of the aorta, CoA, with answers. Question 1. What is coarctation of the aorta, And where is it most commonly located? Answer. Coarctation of the aorta, CoA, is a congenital narrowing of the aorta that impedes normal blood flow. It's most commonly located at the aortic isthmus, just distal to the left subclavian artery. Less commonly, it can occur in the descending thoracic or abdominal aorta. Question 2. Describe the pathophysiological consequences of untreated coarctation of the aorta. Answer. Untreated CoA leads to increased pressure proximal to the narrowing, causing hypertension in the upper extremities and potential damage to the heart, brain, and kidneys. The decreased pressure distal to the narrowing results in weak or delayed femoral pulses and potential underperfusion of the lower body. Long-term, this can lead to left ventricular hypertrophy, heart failure, aortic aneurysm or rupture, and cerebrovascular disease. Question 3. What are the clinical manifestations of coarctation of the aorta in neonates versus older children and adults? Answer. In neonates, CoA may present with signs of heart failure, such as poor feeding, lethargy, and respiratory distress, especially after the closure of the ductus arteriosus. In older children and adults, it may present with hypertension in the upper extremities, weak or absent femoral pulses, differential blood pressure between the upper and lower limbs, and symptoms related to reduced blood flow to the lower body, like claudication or cold extremities. Question 4. How is coarctation of the aorta diagnosed, and what are key findings on diagnostic studies? Answer. Diagnosis is primarily through echocardiography, which can visualize the narrowing, assess the pressure gradient across the coarctation, and evaluate for associated cardiac anomalies. Chest X-ray may show cardiomegaly, rib notching, and the figure of 3 sign. Blood pressure measurement reveals higher readings in the upper extremities compared to the lower extremities. MRI or CT angiography provides detailed anatomical information and is particularly useful for surgical planning. Question 5. Discuss the treatment options for coarctation of the aorta and indications for each. Answer. Treatment options include surgical repair and balloon angioplasty with or without stent placement. Surgical repair, such as end-to-end anastomosis or patch aortoplasty, is preferred in neonates and infants due to the higher restenosis rate with balloon angioplasty in this age group. Balloon angioplasty with stenting, if appropriate, is often considered in older children and adults, especially for recoarctation. Indications for intervention typically include significant pressure gradient, hypertension, and symptoms of heart failure or lower body underperfusion. Question 6. What are potential complications following repair of coarctation of the aorta? Answer. Complications can include recoarctation, aneurysm formation at the repair site, persistent hypertension despite successful repair, aortic dissection, and complications related to the procedure itself, such as bleeding or infection. Long-term surveillance is essential to monitor for these complications. A 6-month-old male infant is brought to the pediatrician for a routine checkup. The parents report that the child has been experiencing difficulty feeding and seems to tire easily. On examination, the pediatrician notes a systolic murmur heard best at the back, weak femoral pulses compared to brachial pulses, and higher blood pressure in the upper extremities compared to the lower extremities. Echocardiography reveals a narrowing of the aorta distal to the left subclavian artery and left ventricular hypertrophy. Which of the following is the most likely diagnosis? A. Atrial Septal Defect ASD, B. Ventricular Septal Defect VSD, C. Patent Ductus Arteriosus PDA, D. Coarctation of the aorta CoA, E. Tetralogy of Fallot TUF. D. Coarctation of the aorta. Explanation: the clinical presentation of weak femoral pulses compared to brachial pulses, higher blood pressure in the upper extremities, a systolic murmur best heard at the back, and echocardiographic findings of aortic narrowing distal to the left subclavian artery and left ventricular hypertrophy are characteristic of coarctation of the aorta, CoA. This condition involves a congenital narrowing of the aorta, which leads to increased pressure proximal to the obstruction and decreased pressure distally, causing the observed clinical signs. Pulmonary valve stenosis. Summary. Description. Pulmonary valve stenosis is a form of congenital heart disease where there is an obstruction to blood flow from the right ventricle to the pulmonary artery due to narrowing at the level of the pulmonary valve. This leads to pressure overload in the right ventricle and subsequent hypertrophy. Epidemiology. Constitutes approximately 10% of all congenital heart defects. Mostly congenital, with rare cases acquired due to conditions like carcinoid syndrome or rheumatic heart disease. Pathophysiology. The obstruction causes the right ventricle to work harder to pump blood through the narrowed valve, leading to right ventricular hypertrophy. Severity can range from mild, which might be asymptomatic, to severe, which can significantly impede blood flow and lead to right heart failure. Clinical features. Mild cases may be asymptomatic. Moderate to severe stenosis can present with exercise intolerance, fatigue, chest pain, and signs of right heart failure in advanced cases. A systolic ejection murmur is typically heard over the left upper sternal border, and there may be a wide splitting of the second heart sound, S2. Diagnostics. Echocardiography. The cornerstone for diagnosis, it evaluates the gradient across the pulmonary valve, right ventricular hypertrophy, and the degree of valve narrowing. Chest X-ray may show post-stenotic dilatation of the pulmonary artery and right ventricular enlargement. ECG might reveal right ventricular hypertrophy in significant stenosis. Treatment, medical management, limited to symptomatic relief in mild cases or preparation for intervention in severe cases. Prostaglandin E1 infusion can be used in neonates to maintain ductal patency for pulmonary blood flow until definitive treatment. Interventional treatment. Balloon valvuloplasty. The preferred treatment for most cases, especially in children and young adults, to dilate the stenotic valve. Surgical commissurotomy. Reserved for cases where balloon valvuloplasty is not feasible or successful, or when there are associated cardiac defects that require correction. Special considerations. Regular follow-up with echocardiography is crucial to monitor the progression and to assess the need for intervention. Patients, especially those post-valvuloplasty or surgery, should be counseled about the risk of infective endocarditis and the need for prophylaxis before dental and certain medical procedures. Educational points for specialists. Understanding the gradient thresholds for intervention and the timing can significantly impact patient outcomes. Awareness of the long-term complications, including the risk of pulmonary regurgitation post-valvuloplasty and the potential need for reintervention, is vital for managing patients with pulmonary valve stenosis. Clinical case, pulmonary valve stenosis. Patient profile, age 5 years, sex male. Presenting complaint, the child was brought to the pediatric cardiologist by his parents due to concerns about his reduced exercise tolerance and shortness of breath during play, which seemed unusual compared to peers. History, medical history. Notable for a heart murmur identified shortly after birth, but was advised to monitor due to its benign nature initially. Family history, non-contributory for congenital heart diseases. Physical examination, general. The child appears well-nourished but becomes easily winded during physical exertion. Vital signs within normal limits for age, with no significant discrepancies in oxygen saturation levels. Cardiovascular exam reveals a harsh systolic ejection murmur best heard at the left upper sternal border. The murmur intensifies with standing and diminishes with squatting. Wide splitting of S2 noted. Diagnostic workup. Echocardiography demonstrates a doming pulmonary valve with a peak gradient of 50 mm/Hg across the pulmonary valve, indicating moderate pulmonary valve stenosis. Right ventricular hypertrophy is noted. ECG shows evidence of right ventricular hypertrophy. Chest X-ray. Normal heart size with mild poststenotic dilation of the pulmonary artery. Management plan. Given the symptomatic presentation and echocardiographic findings indicating significant obstruction, interventional treatment. The patient is scheduled for balloon valvuloplasty, the preferred method to relieve the obstruction at the pulmonary valve. Pre-procedure. The child is started on mild diuretics to manage any right ventricular strain symptoms and advised on activity modification until treatment. Follow-up. Post-procedure, the child will be monitored for immediate complications and improvement in symptoms. Follow-up echocardiograms will be scheduled to assess the success of the valvuloplasty and monitor for potential pulmonary regurgitation, a common sequelae of the procedure. The family is educated about the signs of infective endocarditis and when to seek medical attention. Discussion points for specialists. The importance of a detailed physical exam in diagnosing pulmonary valve stenosis, given the characteristic changes in the murmur with different maneuvers. The role of balloon valvuloplasty in the management of pulmonary valve stenosis, and its advantages over surgical intervention in suitable candidates. Long-term follow-up strategies for patients post-valvuloplasty, focusing on the potential development of pulmonary regurgitation and the need for subsequent interventions. Oral exam questions on pulmonary valve stenosis with answers. Question 1. What are the typical auscultatory findings in a patient with pulmonary valve stenosis, and how might these findings change with maneuvers? Answer. In pulmonary valve stenosis, you typically hear a systolic ejection murmur, best heard at the left upper sternal border. This murmur can radiate to the back and neck. Maneuvers that decrease venous return to the heart, like standing, can intensify the murmur due to reduced right ventricular volume, whereas maneuvers that increase venous return, like squatting, can diminish the murmur's intensity. Question 2. Describe the pathophysiological mechanism leading to right ventricular hypertrophy in pulmonary valve stenosis. Answer. Pulmonary valve stenosis causes an obstruction to the outflow of blood from the right ventricle into the pulmonary artery. To overcome this obstruction and maintain adequate pulmonary blood flow, the right ventricle has to generate higher pressures, leading to pressure overload. Chronic pressure overload results in right ventricular hypertrophy as the myocardial muscle thickens to compensate for the increased work required to pump blood through the narrowed valve. Question 3. What is the gold standard for diagnosing pulmonary valve stenosis, and what key findings would you expect? Answer. Echocardiography is the gold standard for diagnosing pulmonary valve stenosis. Key echocardiographic findings include doming of the pulmonary valve during systole, poststenotic dilation of the pulmonary artery, and measurement of the pressure gradient across the pulmonary valve, which quantifies the stenosis's severity. Right ventricular hypertrophy may also be observed as a result of the increased workload on the right ventricle. Question 4. What are the indications for intervention in pulmonary valve stenosis, and what are the preferred treatment options? Answer. Intervention in pulmonary valve stenosis is indicated for symptomatic patients or those with evidence of right ventricular dysfunction or significant pressure gradients, typically 40 mm/Hg, across the pulmonary valve. The preferred treatment for most cases is balloon valvuloplasty, which involves the use of a catheter to place and inflate a balloon at the site of stenosis, thereby widening the narrowed valve. Surgical valvotomy may be considered if balloon valvuloplasty is not feasible or effective. Question 5. Discuss the potential complications of untreated severe pulmonary valve stenosis. Answer. Untreated severe pulmonary valve stenosis can lead to progressive right ventricular hypertrophy and dysfunction, eventual right heart failure, and potential development of arrhythmias such as atrial flutter or fibrillation due to the increased strain on the right heart. Additionally, severe right ventricular hypertrophy can compromise left ventricular filling due to ventricular interdependence, leading to reduced cardiac output and systemic symptoms. Question 6. Explain the potential sequelae of balloon valvuloplasty for pulmonary valve stenosis and how patients are monitored post-procedure. Answer. Balloon valvuloplasty can lead to immediate complications such as valvular regurgitation, right ventricular outflow tract injury, or arrhythmias. Long-term sequelae include the potential for restenosis or progressive pulmonary regurgitation. Patients are typically monitored post-procedure with serial echocardiograms to assess valve function, right ventricular size and function, and to monitor for restenosis or regurgitation. Clinical follow-up focuses on symptom management and detection of potential complications. A 4-year-old boy is brought to the pediatric clinic due to a heart murmur detected during a routine physical examination. The child's parents report that he tires more easily than his peers during playtime. On examination, the pediatrician notes a prominent systolic ejection murmur best heard at the left upper sternal border, and the child has a normal S2 with wide splitting. An echocardiogram reveals thickening of the pulmonary valve leaflets with a doming appearance during systole and a peak gradient of 45 mm/Hg across the pulmonary valve. Which of the following is the most appropriate next step in management for this patient? A. Immediate surgical commissurotomy. B. Start a beta blocker therapy. C. Observation and endocarditis prophylaxis. D. Balloon valvuloplasty. E. Initiate prostaglandin E1 infusion. Answer. D. Balloon valvuloplasty. Explanation. The child's symptoms, along with echocardiographic findings of pulmonary valve stenosis with a significant pressure gradient, 45 mm/Hg, indicate the need for intervention to relieve the obstruction. Balloon valvuloplasty is the treatment of choice for pulmonary valve stenosis, especially in children, due to its efficacy in relieving the stenosis and its less invasive nature compared to surgery. Immediate surgical commissurotomy, A, is typically reserved for cases where balloon valvuloplasty is not feasible or unsuccessful. Beta blocker therapy, B, is not indicated in the management of pulmonary valve stenosis. Observation and endocarditis prophylaxis, C, might be appropriate for mild cases, but this child's significant pressure gradient and symptoms warrant intervention. Prostaglandin E1 infusion, E, is used to maintain ductal patency in conditions like ductal-dependent congenital heart diseases, which is not applicable in isolated pulmonary valve stenosis. ASHTARB, Eisenmenger Syndrome Summary. Description. Eisenmenger Syndrome is a complex condition that evolves from an unrepaired cardiac defect with an initial left-to-right shunt, leading to the development of pulmonary hypertension, reversal of the shunt to right-to-left, and resultant cyanosis and polycythemia. Etiology. Originates from congenital heart defects, CHDs, that create left-to-right shunts, such as Ventricular Septal Defect, VSD, Atrial Septal Defect, ASD, patent Ductus Arteriosus, PDA, and complete Atrioventricular Septal Defect, AVSD. Pathogenesis. The chronic increase in pulmonary blood flow from the shunt leads to pulmonary vascular remodeling, irreversible pulmonary arterial hypertension, PAH, and subsequent right ventricular hypertrophy. Once pulmonary pressures exceed systemic pressures, shunt reversal occurs, manifesting as cyanosis and polycythemia. Clinical features. Early stage. Minimal symptoms related to the original shunt. Late stage. Features of cyanosis, digital clubbing, and complications related to PAH and right-to-left shunting, such as chest pain, exertional dyspnea, and hemoptysis. Diagnostic workup. Echocardiography. Identifies the underlying cardiac defect, assesses shunt direction, and estimates pulmonary and right ventricular pressures. Cardiac catheterization. Gold standard for measuring pulmonary artery pressures, assessing the severity of PAH, and evaluating shunt reversal. Treatment. Medical management focuses on controlling symptoms of PAH with drugs such as endothelin receptor antagonists, e.g. bosentan, phosphodiesterase type 5 inhibitors, e.g. sildenafil, prostacyclin analogs, e.g. epoprostenol for severe cases. Oxygen therapy may relieve hypoxemia but must be used cautiously. Iron supplementation. For managing secondary erythrocytosis. Anticoagulation, considered in patients with PAH to prevent thrombotic complications. Surgical intervention, limited options due to the advanced nature of the disease. Heart-lung transplantation is considered in end-stage cases but is limited by donor availability and the high-risk nature of the procedure. Special considerations. Eisenmenger syndrome is a contraindication for corrective surgery of the original cardiac defect due to the high risk of mortality associated with the severe pulmonary vascular disease. Management requires a multidisciplinary approach with expertise in adult congenital heart disease and pulmonary hypertension. Educational points for specialists. Recognizing the transition from a simple left-to-right shunt to Eisenmenger syndrome is crucial for timely intervention before irreversible pulmonary hypertension develops. Understanding the pharmacologic management of PAH and its role in improving quality of life in Eisenmenger syndrome. Awareness of the indications for advanced therapies, including transplantation, and the associated complexities in Eisenmenger patients. Clinical case, Eisenmenger syndrome. Patient profile. Age, 24 years, sex, female. Presenting complaint. A 24-year-old woman presents to the cardiology clinic with worsening exertional dyspnea, cyanosis, and episodes of syncope. She has a known history of a large unrepaired ventricular septal defect, VSD, diagnosed in childhood. History. Medical history. Diagnosed with VSD in early childhood, but surgical repair was not pursued due to family preferences and lack of symptoms at the time. Over the years, she developed increasing intolerance to exercise, with recent onset of cyanosis and fainting spells. Family history. Non-contributory. Physical examination. General. The patient appears cyanotic with noticeable digital clubbing. Oxygen saturation on room air is 88%. Cardiovascular exam. A loud holosystolic murmur is audible at the left lower sternal border, along with a single S2. Signs of right ventricular heave are present. Diagnostic workup. Echocardiography reveals a large VSD with bidirectional shunting and severe pulmonary and right ventricular hypertrophy. Cardiac catheterization confirms elevated pulmonary artery pressures exceeding systemic pressures, consistent with Eisenmenger physiology. Complete blood count CBC shows polycythemia with a hematocrit of 65%. Management plan. Given the advanced stage of the disease with Eisenmenger physiology, pulmonary hypertension management, initiation of endothelin receptor antagonist, e.g. bosentan, and phosphodiesterase type 5 inhibitor, e.g. sildenafil, to manage pulmonary hypertension and alleviate symptoms. Symptomatic management. Low-dose aspirin for thromboprophylaxis, considering the hypercoagulable state associated with Eisenmenger syndrome. Phlebotomy may be considered to manage symptomatic polycythemia with careful volume replacement to avoid dehydration and hypovolemia. Oxygen therapy. Supplemental oxygen to alleviate hypoxemia, used cautiously to avoid suppressing respiratory drive. Lifestyle adjustments. Counseling on avoiding strenuous activities and situations that may exacerbate hypoxemia or dehydration. The patient is scheduled for regular follow-up appointments to monitor the effectiveness of therapy, adjust medications as needed, and evaluate for potential complications associated with Eisenmenger syndrome and pulmonary hypertension. Discussion points for specialists. The complexity of managing Eisenmenger syndrome lies in balancing the treatment of pulmonary hypertension while acknowledging the irreversible nature of the shunt reversal and avoiding interventions that could destabilize the delicate hemodynamic balance. The importance of a multidisciplinary approach involving cardiologists, pulmonologists, and hematologists to address the multisystem effects of Eisenmenger syndrome. The need for patient education on the chronic nature of the condition, the importance of adherence to therapy, and the recognition of symptoms warranting immediate medical attention. Oral exam questions on Eisenmenger syndrome with answers. Question 1. Describe the pathophysiological progression from a simple congenital heart defect with a left-to-right shunt to Eisenmenger syndrome. Answer. Eisenmenger syndrome develops when a congenital heart defect with a left-to-right shunt, such as a VSD, ASD, or PDA, leads to increased blood flow through the pulmonary circulation. Over time, this causes pulmonary vascular resistance to rise, leading to pulmonary hypertension. As pulmonary pressures increase to surpass systemic pressures, the shunt direction reverses to right to left, causing cyanosis, polycythemia, and the clinical picture of Eisenmenger syndrome. Question 2. What are the hallmark clinical features of Eisenmenger syndrome? Answer. The hallmark features of Eisenmenger syndrome include central cyanosis, digital clubbing, and polycythemia. Patients may also exhibit symptoms of pulmonary hypertension and right heart failure, such as exertional dyspnea, chest pain, syncope, and hemoptysis. Question 3. Why is surgical correction of the original cardiac defect generally contraindicated in patients with Eisenmenger syndrome? Answer. Surgical correction of the original cardiac defect is contraindicated in Eisenmenger syndrome due to the irreversible changes in the pulmonary vasculature and the high risk of mortality associated with surgery. The pulmonary vascular disease in Eisenmenger syndrome results in fixed pulmonary hypertension, and closing the shunt would not alleviate the pulmonary hypertension, but could lead to decompensated heart failure. Question 4. What is the mainstay of medical management for Eisenmenger syndrome, and how do these treatments work? Answer. Medical management of Eisenmenger syndrome focuses on controlling symptoms of pulmonary hypertension and preventing complications. Treatments include endothelin receptor antagonists, e.g. bosentan, that block endothelin 1's vasoconstrictive effects on pulmonary vessels, phosphodiesterase 5 inhibitors, e.g. sildenafil, that increase nitric oxide availability and promote vasodilation, and prostacyclin analogs, e.g. epoprostenol, that directly dilate pulmonary vessels and inhibit platelet aggregation. Oxygen therapy and anticoagulation may also be used to manage hypoxemia and reduce thrombotic risks, respectively. Question 5. Explain the significance of polycythemia in Eisenmenger syndrome and its management. Answer. Polycythemia in Eisenmenger syndrome is a compensatory response to chronic hypoxemia from the right to left shunt. While it can improve oxygen delivery by increasing the oxygen-carrying capacity of the blood, it also increases blood viscosity, raising the risk of thrombotic events. Management may involve periodic phlebotomy to reduce hematocrit levels, with careful volume replacement to maintain intravascular volume and avoid dehydration. Question 6. Discuss the potential role of lung or heart-lung transplantation in Eisenmenger syndrome. Answer. Lung or heart-lung transplantation may be considered for select patients with Eisenmenger syndrome who have severe refractory pulmonary hypertension and right heart failure, significantly impacting their quality of life and prognosis. However, transplantation is limited by donor availability and is associated with significant perioperative and long-term risks. Candidates for transplantation require thorough evaluation to assess suitability and potential for benefit from this high-risk intervention. A 25-year-old woman with a known history of unrepaired ventricular septal defect presents to the clinic with worsening exercise intolerance and cyanosis. Physical examination reveals central cyanosis, digital clubbing, and a loud systolic murmur, best heard over the left sternal border. An echocardiogram shows right-to-left shunting across the ventricular septal defect, with evidence of severe pulmonary hypertension. Her hematocrit is found to be 65%. Which of the following is the most likely diagnosis for this patient? A. Primary pulmonary hypertension. B. Tetralogy of Fallot. C. Eisenmenger syndrome. D. Chronic thromboembolic pulmonary hypertension. E. Atrial septal defect with right-to-left shunt. Answer. C. Eisenmenger syndrome. Explanation: patient's clinical presentation of cyanosis, digital clubbing, a history of a congenital heart defect with a systolic murmur, and echocardiographic findings of right-to-left shunting across a ventricular defect with severe pulmonary hypertension are characteristic of Eisenmenger syndrome. This syndrome arises as a late complication of uncorrected left-to-right shunt congenital heart defects, where progressive pulmonary vascular disease leads to pulmonary hypertension and reversal of the shunt to right to left, causing cyanosis and polycythemia.